Hi, this is Manos Brilakis, and this is video 7.1 for the Manual of CTO Interventions. The goal of this video is to discuss about how to decide which patients should undergo CTO PCI. This is something that is debated, and for many operators, the indications for performing CTO PCI are completely dissociated from the underlying anatomy. But for every PCI, and for that matter, for every procedure, that procedure should be performed if the potential benefits outweigh the potential risks. And how do we decide about the benefits and the risk of the procedure? This is where the patient characteristics come in, the baseline clinical condition, the lesion complexity, the patient comorbidities, but also this depends on the operator experience and expertise. So we'll cover those one by one. First of all, benefits start from the baseline patient symptoms or the impact of the potential revascularization on the patient's quality and quantity of life. This is highlighted in the 7 global principles of CTO PCI that state that the principal indication of CTO PCI is to improve symptoms. Several trials have looked at this. The EuroCTO showed symptomatic improvement compared with medical therapy alone, but Decision CTO did not, although Decision CTO had multiple limitations. 2 other smaller single-center studies showed improvement in exercise capacity and quality of life, and 2 studies did not show any change in ejection fraction after CTO PCI. The benefits seem to be more in patients who are depressed, and many of the patients with CTO appear to have depression, likely because of limitation of their underlying clinical functioning. We do have some studies showing that if you fail, you're going to have worse outcomes after CTO PCI than if you succeed, but of course there's a lot of underlying bias there. And we do know that patients who participated in Decision CTO did not only have the CTO, but had multiple other lesions, and also they had mild symptoms at baseline, and 1 in 5 crossed over from medical therapy to CTO PCI at baseline. We know that if a patient with CTO is unlucky enough to have an acute coronary syndrome, then both the short and medium-term outcomes are going to be worse. They're going to have much higher mortality, both immediately and during prolonged follow-up. We also know that in patients who have a CTO and are unlucky enough to develop myocardial infarction, they're more likely to develop out-of-hospital cardiac arrest, and the physiology behind it is simple. It is one thing to have ischemia in the territory of the culprit vessel only for the acute coronary syndrome. However, if you have a baseline CTO and then you get occlusion of another vessel, then the area and the extent of ischemia is significantly larger. Rarely we do revascularization because of intractable arrhythmias. In terms of ejection fraction, a meta-analysis has demonstrated that the overall impact is small, 2.6% change in ejection fraction. But if the baseline ejection fraction is low, less than 45%, there was a much more substantial increase in ejection fraction of 5.5%. However, as mentioned before, the 2 randomized control trials that looked at this, the study by Masayeki, the REVASC trial, as well as the EXPLORE trial, they did not show any significant change in ejection fraction. Another question that comes up often is about the presence of good collaterals. Should CTO PCI be done in those cases? And what we have found out is that if you do a pressure wire after crossing but before putting stents, every single patient is going to have an ischemic FFR. Therefore, the patients are going to be ischemic. So the presence of good collateral does not necessarily mean that the patient does not stand to benefit from coronary revascularization. So who should get CTO PCI? It all depends on the baseline symptoms and possibly ischemia and left ventricular dysfunction. If the patients have symptoms, which is the main indication for CTO PCI in 2023, then revascularization can potentially help to improve that. If the patient have previous bypass or single vessel coronary artery disease, then CTO PCI is the way to go. But in patients who have multivessel coronary artery disease, especially complex disease, for example with high syntax scores who are good surgical candidates, coronary bypass remains the standard of care. So CTO PCI is a tool. It's a revascularization tool. It is not for everyone, but it can benefit patients, especially those who are highly symptomatic. What do the guidelines say? The ACC/HA guidelines 2021 actually give a class 2B level of evidence B for CTO PCI because of the conflicting results between the EuroCTO trial as well as the Decision CTO trial. But then the European Society of Cardiology guidelines, they do give a 2A indication level of evidence B. Rarely, CTO PCI is done for other indications such as failing saphenous vein graft. This is an example of an occluded vein graft that was recanalized acutely, but the long-term prognosis is limited. The occluded vein grafts quite often reocclude fairly soon after being recanalized. So in that patient, a few weeks later, he came back, the native RCA was recanalized, and this has a much higher likelihood for long-term patency. Also rarely, CTO PCI techniques can be used in non-CTO PCI, for example, to treat complications such as acute vessel closure using antegrade dissection reentry or the retrograde approach. Now, the benefits depend not only on the impact of coronary disease on the patient functioning, but also depends on the likelihood of success. And this depends on the operator experience, but also on the lesion characteristics, and also to some extent on the comorbidities. The more cases an operator does, the higher the success and the lower the complications. This is true for every procedure, and especially for a highly complex procedure such as CTO PCI. In terms of lesion complexity, lesion complexity can be assessed using the dual injection, which is standard for pretty much every CTO PCI unless there are absolutely no contralateral collaterals. And then we look at the clinical characteristics of the lesion. We look at the proximal cap, the lesion length, the distal vessel quality, and the presence of collaterals. We can actually use specific scores such as the JCTO score or the Progress CTO score to determine the difficulty of the lesion and the likelihood of success. But even in the most complex lesions, such as those with Progress CTO score of 3, about 80% success can be achieved. Increasingly, we are doing coronary computed tomography angiography, and this can be actually more accurate for predicting the success. It can help determine the location of the proximal cap, the presence of tortuosity, the presence of calcium, and also is very accurate for determining the occlusion length. In terms of the patient comorbidities, this can be cardiac and non-cardiac. It can be the presentation. Previous coronary bypass is traditionally associated with lower success rates, presence of heart failure, atrial fibrillation, high filling pressures, valvular heart disease, and other factors such as advanced age, one of the most important predictors of complications, diabetes, renal failure, lung disease, peripheral arterial disease, bleeding risk, and frailty. There are multiple complications that can happen in CTO PCI as in any PCI, both coronary and non-coronary and non-cardiac, and it is important to have an estimate of what is the risk of having a complication for every specific patient. We do know that CTO PCI is associated with higher risk compared with non-CTO PCI. And we also know that if we use more advanced techniques, such as antegrade dissection reentry and the retrograde, the risk goes up, both for MACE, but also for perforation and acute myocardial infarction, as well as mortality. And despite the progress we've achieved and the very high success rates, this is from several highly experienced centers in North America that participated in the Teleflex FDA approval study, and all the success was about 95%. MACE was high. Granted, a large proportion of this 19% was post-procedural myocardial infarction, which is sometimes of unclear clinical significance. However, the clinical perforation was 10.7%, with 5.3% of patients requiring pericardiocentesis or recovered stent. There are actually scores for estimating the risk of complications. The most recent one is the Progress CTO Complication Score family that can help estimate the risk of MACE, mortality, pericardiocentesis, and myocardial infarction. So who should undergo CTO PCI? As we discussed before, the key is the benefits and the risks. CTO PCI should be done when the benefits are more than the potential risks, and this should be decided by a heart team as well as with a careful and close discussion with the patient and full explanation of what can be expected. Thank you.